All right, everybody, thanks for joining. We have, as I mentioned earlier, we have a very timely talk today that I think can help spur some ongoing conversation about some of the things that we were discussing as a group not too long ago. So today we're very excited to welcome Dr. Herr. Dr. Herr is from the California Pacific Medical Center in San Francisco, where he's an advanced heart failure and transplant cardiologist. And also at the, well, I guess it's the Center for Advanced Heart Failure Therapies in San Francisco, and then the Palo Alto Medical Foundation. As we were chatting, Dr. Herr is originally from upstate New York in Syracuse, went to complete his undergraduate studies at Roanoke College, and then went to the University of Texas for medical school. Then he made the wise decision to go out to the West Coast, it seems, and did his internal medicine residency at UCSF and his general cardiology and advanced heart failure training at Cedars-Sinai. He joined the team at CPMC, which is California Pacific Medical Center, in 2015, where he's involved in medical education and clinical research, and he is the program director for their Advanced Heart Failure Fellowship. He's also the director of continuing medical education at Palo Alto Medical Foundation, and has been some of the clinical research that he's been active with includes being the PI for several trials such as GUIDE-HF, Momentum 3, Galactic, and Paraglide. And he published a paper in the Journal of Cardiac Failure where he was the primary author towards the end of 2021, which caught my eye. And I thought that as we've had talks about how to optimize referral practices to our advanced heart failure group, this would be a really interesting talk to have with him about the data that he came across and kind of get his thoughts about what programs such as ours might be able to do to attract or be able to get patients referred to us in a more timely manner. So Dr. Herr, thank you so much for making the time, and please, you're welcome to go ahead and get started.
Well, thank you, Dr. Beasley, and everybody at Yale. I really appreciate the opportunity to chat with you all today. And I'm a little bit warmer probably than you all are, so I hope you guys are all staying warm. Let me go ahead and share my screen here, which hopefully will work. One sec. Okay, after 2 years of using Zoom, I finally figured out how to share and do the presenter view at the same time. So let me try and do that.
That's a skill you need to teach.
Yeah. So let's see if it works here, actually. Sorry, 1 second here.
That's okay.
Maybe I didn't get it right.
No, looks good now.
Actually, here, yeah. So let me just, then you switch it here. Stop this. And reshare like that. There we go. Okay, can you guys see the slides okay?
Yeah, yep, looks great.
Excellent. And it's just the regular. Okay, very good. Well, again, thanks again for the opportunity to be here today. I'm really excited to have a chance to talk to you about some exciting research that we've been doing, and I think a topic that we all talk about in our own programs, and wonder kind of what's happening across the country, and how do we figure out sort of how do our patients get to us? I think we spend a lot of time talking about who should be referred and what's the appropriate timing of referral, but sort of thinking about when patients actually are referred and how do we maximize that. So again, I don't really have any disclosures that are relevant to this today. I have done some consulting work for Abbott and also have some research funding from them. So as we all know, heart failure is an epidemic, right? We have 6 million people in the United States who have heart failure, and every year we're getting more than 600,000 new cases every year. It's a high rate of hospitalization, over 1 million per year, and it is a #1 reason for people to be hospitalized over the age of 65. And we spend a ton of money, right? $30 billion a year in healthcare expenditures related to heart failure, and almost $2 billion just in office visits, and that's projected to reach over $50 billion in the next couple of years. And advanced heart failure, where we spend most of our time working, is obviously marked by poor quality of life and high morbidity and mortality, despite good medical therapies. And what's good about heart failure is we have a lot of different options for people, right? We have guideline-directed medical therapy, we have defibrillators and valve interventions now, we have remote hemodynamic monitoring, things like CRT that can all help us take care of these patients, and we've done a good job. We've been able to keep them alive longer and doing better with better qualities of life. But even despite all of those things, we still have patients that progress to an advanced state, right? And at that point, we have to start thinking about sort of what are the things that we can do to help those people, and trying to figure out how to maximize the benefit that they may get from those treatments. And as you guys all well know, we have things like heart transplant, mechanical support, and mechanical circulatory support, and supportive care and hospice, which is equally important thing for us to talk about in this population. And as we all know, as heart failure specialists, I think the care of the heart failure patient has become, because of all these different technologies and treatments and things that we have, has become really, really, really complicated, right? And so as each individual cardiovascular specialty becomes more and more specialized and has its own technologies to consider, sort of taking a multidisciplinary approach to managing a heart failure patient is really important. And I really like this graphic on paper that was published 2 years ago. And it is, I think thinking about sort of when the patient becomes sicker, and how we move from sort of the primary cardiology provider to being that sort of heart failure specialist as the quarterback for that patient, to be able to kind of help collaborate and coordinate these different technologies and treatments that we have in other disciplines. And so really focusing on how we manage these patients. And so, again, because of the complexity of this, it really it takes referrals in order to get the patient to the heart failure specialist to really be able to maximize the benefits that they might have from these different technologies and treatments. And so we spend a lot of time talking in our own group, and I imagine you all do too, about sort of what's the best way to get patients into your program so that they can be able to benefit from these things. And there's a lot of talking about this, and guideline writing and so forth, and consensus writing about sort of what is the appropriate time to refer a patient, and what are the sort of different things to think about clinically, and sort of when is too early and when is too late, because there really is this golden window. And I think most of you have probably seen this position statement that was just published very recently here from the AHA about sort of guidance of timely referral to advanced heart failure centers, right? And then back in 2017, 2018, the consensus document from the ACC that came out again, thinking about sort of optimization of care pathways for patients with heart failure. And I think that the bottom line comes down to, in a lot of different situations, is such that we have this golden window of opportunity to get a patient into an advanced heart failure program, to be able to help them have the most success that they can, right? To be able to kind of access these more complicated or more collaborative, I should say, treatments down the line, whether it's surgical or interventional or whatever. And so I think, fairly solidly, most people, agree on sort of what's the appropriate sort of clinical timing of referral, right? But sort of the question remains sort of when do patients actually get referred, right? And so, there's I think a difference between sort of what we know is kind of the right timing for this, but what's actually happening. And so despite these guidelines and all these things that are out there, and all the talk that we have, there's still a lot of questions about sort of, what is the real world situation when it comes to referrals, right? So how do patients get to us? We know which patients should get to us, but A, are they all getting to us, which we all know the answer to that is no. And B, how do they come to us? And then how do we take that information and build interventions to try and maximize the number of patients that can be helped? And so questions like, so which cardiologists are referring patients for advanced heart failure therapies, right? How do they get to us? Where are they coming? What are the triggers from their level, and from that provider's level, sort of that led them to send a referral, right? And so what are the characteristics actually of the patients that are really getting referred? And then so what happens to them when they get into the program? How, what are the decision-making characteristics? What are the outcomes related to these things? And so our goal in this study was really to just basically describe the patterns of patient referrals and decision making in a multi-center cohort. We probably all individually look at these things, on our own centers, but thinking about getting as big a group of patients as possible to sort of have an understanding of what might be going on out there. And so in terms of our study population, again, we did a retrospective chart review of patients that were referred and completed an evaluation for advanced heart failure therapies. We had 9 centers across the United States, and we ended up with 515 referrals total. And we basically obtained all the data from the EMR. We looked at selection records and so forth. We were sort of only using non-protected health information that was de-identified. We put everything into a single database. We collected information such as demographics, clinical characteristics, etiologies of heart failure. We also wanted to look at the referring physician. We want to know, what type of cardiologist were they, or were they not a cardiologist? What was the sort of location in reference to the center? What was the reason why they sent the patient? What was the clinical trigger? And then we wanted to look at the back end too, sort of as they came through the program, what was eventually the type of evaluation that they got, how sick were they at the time that they got evaluated, and then what happened. And we used mostly descriptive statistics, and we used chi-square for any comparisons that we were doing. And so these are the centers that we had in the trial. We had 9 centers, as I mentioned, our center out in California here at CPMC. We also had Scripps Clinic down in San Diego, MedStar in DC, UNC in Chapel Hill, Penn. We had Mount Sinai, as well as Montefiore in New York, Cleveland Clinic, and St. Vincent St. Vincent in Indianapolis. And so we had a pretty wide range of programs here and a pretty wide geographic distribution. So we felt like that, and again, differing in size of volume of programs, anywhere from up to 100 VADs a year to 50 to 60 transplants a year. So a fairly wide range of patient population and sort of a real life kind of situation. So the overall patient population, I think, is important to talk about. So if we just look at the total population of patients that we had, most of them were men, 73% of them were men, and most of them were white, so more than half, 55.8%. So again, consistent with other things that you've seen in advanced heart failure, is an underrepresentation of women in this, and we'll talk about that here in a little bit later as well. And there's some future stuff that we have coming out that we'll talk about that as well. It's only 26% were women. The bulk majority of patients actually had non-ischemic cardiomyopathy, 55%, almost 56. And then the next highest rate was ischemic cardiomyopathy. So again, probably as expected, and sort of a smattering of other things like restrictive cardiomyopathy, hypertrophic or congenital heart disease, repeat transplant or ARED or valvular disease. So sort of important to notice that really heavily predominantly male and a white population. And if you look at just sort of the overall sort of sickness of patients, right, a lot of them, almost 75% of them had an EF of less than 25%, right, but more than half of them had an EF of less than 20%. So very sick at the time that they were actually getting referred. And the bulk majority of the patients, 75% almost, were intermex 1 to 3. So at that point, most of the patients were either in critical cardiogenic shock, about 10%, or they were dependent on inotropic therapy or temporary mechanical support, and either not doing well or stable, but dependent on it. So the patients were really sick when they finally got referred. And I think that's, obviously one of the things that we always talk about is sort of not getting to the point where patients are too late at the time that they get referred. And so it really does limit your options if this is sort of the first time that you see patients, right? In terms of where referrals came from, most of the patients were, either in their sort of general metropolitan area of the patient's, the center's area. Very few came from kind of out of state or out of metro area, and about half and half came sort of either within the program's network. And we define that as sort of, if you had a network of hospitals all under the same system or so forth, that was within the network. So about half and half there between inside or outside the network. And the bulk majority of patients actually were, again, in the inpatient setting. So if you look at both urgent inpatient evaluations, 43%, and ICU level sort of emergency evaluations at 15%. So more than half, 60% or so, were in the inpatient setting. And we just looked at sort of who was the referring cardiac specialist, right, who sent the patient. So we define this as sort of the first cardiovascular disease physician that basically, touched the patient before they came into the program. And interestingly enough, 49% of those patients were referred by a heart failure specialist. So almost half, which we all know there aren't, we're probably a smaller number of cardiology specialists, right, in the country. So, probably out of proportion to what you would expect to see, just based on the number of cardiologists that are in the community, right? About a third of them came from general cardiologists, and then the next highest being from interventional cardiologists, and the least actually from electrophysiology and imaging as well. And this is just looking at sort of INTERMACS profiles based on the person who referred the patient, right? And sort of what's the level of sickness that they were. And if you look at sort of the sickest of the sick here, INTERMACS 1, the patients who were referred mostly either came from heart failure cardiologist, interventional cardiologist, or cardiac surgeon, which makes some sense, right? I mean, you have the interventionalist is the one working STEMIs in the cath lab and so forth. And, cardiac surgeons are often involved in that, whether it's from ECMO or from, some complications in the OR or in the cath lab, even from that sense. So, but again, the bulk of the patients were INTERMACS 2 and 3, which again, sort of is highlighted here. So then we went back and looked at sort of what was the clinical trigger for patients' referrals. We always wonder, we know sort of by guidelines and so forth, sort of what are the things that we should be looking at with our patients in terms of referring them, but sort of what's actually the reality, what are people actually thinking about, right? And if you just look at the overall population here on the left, most patients were referred for worsening heart failure, right? About a third of them. And we define worsening heart failure as patients who had progressive symptoms, who were intolerant to medications, had recurrent hypotension. And so 30% of the patients came for that reason. And then another high rate here was hospitalization and inotrope dependence, right? So 19% for both of them. Cardiogenic shock, again, a fairly large proportion as well. So top 4 reasons here, basically worsening heart failure, hospitalization, inotrope dependence, and cardiogenic shock. So again, indicating kind of how sick patients are when you look at sort of patients who have been hospitalized, they're dependent on inotropes, and those who are in shock, all sort of equally likely almost. Then we went and looked at, sort of the type of cardiologist. Was there any difference in the sort of reason why patients were referred based on the type of cardiologist that saw the patient first? And if you look at, again, heart failure cardiologists, worsening heart failure being the most common there, these are the top 3 reasons in each individual specialty. Hospitalization rate was high. Hospitalization was the highest in general cardiologists. Cardiogenic shock, again, in interventional cardiologists makes a little bit of sense there. EP, again, worsening heart failure, although you would expect, I would think, potentially, more things like ventricular arrhythmia or ICD discharges to be sort of a more common reason why an EP doctor might send someone to heart failure specialist. But again, the numbers, unfortunately, are a little bit small in these other groups outside of heart failure cardiologists. And again, cardiac surgeons here, again, hospitalization. So the same theme, basically, the beyond just looking at the total population is very similar amongst each individual type of specialist. And other, so that's, we're looking at pulmonary hypertension, valvular disease, renal failure as a trigger for referral. So when we looked at just the evaluation types, what was performed for these patients, about 54% of the patients, almost 55, both underwent evaluation for LVAD and transplant. About 23% underwent only a transplant evaluation, and then 21% underwent just an LVAD evaluation. So most patients were getting evaluated for all types of advanced heart failure therapies. And then when you look at the outcome overall, 62.5% of patients were offered at least one advanced heart failure therapy, so either LVAD or transplant or both. And only 43% were actually accepted for heart transplant. So less than half of patients who were referred were actually accepted for transplant. But more commonly, patients were accepted for LVAD when they were evaluated, so 57%. So it was more likely to get accepted for an LVAD if you were evaluated for it than if you were for a transplant. And again, I think that makes some sense because, there's, I think, more, obviously we have, more complicated medical issues that might affect transplant candidacy versus VAD candidacy and psychosocial situations, things like that, that may make people more appropriate for one therapy or the other. So, I think not unlikely that we would have seen this type of pattern. So then we wanted to know, what was the reason the patients were getting turned down for therapies, right? So why were our patients not getting offered particular types of therapies? And so we categorized reasons basically into either too well for therapy, right? So they deemed that they were too early for consideration. They were too sick, right? Either due to medical comorbidities or overall critical illness, things like that. They had psychosocial contraindications. Either the patient just declined, didn't want to do it. Malignancy obviously takes into account right ventricular failure, especially in mechanical circulatory support or active infection. And what we found was that in mechanical support, about 38%, again, overwhelming majority of reasons to get turned down is patients were too sick, right? And then both psychosocial and being deemed too well for MCS were equal in proportion. And so, again, about 20% of those patients who were declined for both psychosocial reasons or for being thought to be too well. So again, the theme here in that patients are very, very sick when they get referred to us, and unfortunately limits their options, right? We also saw a significant number of patients actually declined MCS, 14%. So it was interesting to see, but much higher rate than those who declined transplant. And then if you look at heart transplant on the right here, we had 213 patients who were evaluated for heart transplant. And again, almost half of them were declined because they were too sick. 28%, 28.5% basically because of psychosocial issues. And then again, 15% because they were thought to be too well. So, very consistent theme of patients being very sick by the time they get to us, and that really limits their treatment options. And so, I think as a physician who, we all try to advocate for our patients, we got to, figure out how do we increase access to these therapies. Then we also looked at sort of the patients that got turned down and sort of what were the alternative treatment pathways. And I think importantly for us to point out is that, most of the time, unfortunately, like 3/4 of the time, there wasn't an alternative treatment pathway that was described basically, so about a third or just over a third, 37% of patients were not offered any therapy. And then about 20% of those were too well for that. So if you took out those patients and just looked at those who were not too well but didn't get offered something, sort of what happened to them, almost a third of them were given home inotropic therapy, which I think is interesting, but only, less than 15% were offered hospice, which in reality, probably most of those patients, and again, we can't necessarily know this, but most of those patients might qualify for hospice, right, given their end stage disease. But again, I think, looking at sort of making sure that we're thinking about all treatment pathways in these patients and sort of what's the way to try to maximize benefit if we can't offer them VADs or transplants. So then we wanted to look at sort of, was there any difference between specialists in terms of sort of the reasons why they sent referrals, sort of what was the outcome and so forth. And unfortunately, I think the population size is fairly small in some of our types of specialists. So we decided to combine them into heart failure versus non-heart failure cardiologists to see if there was any difference there. And we did see some statistically significant difference in terms of the cause of referral by patients who were referred by heart failure cardiologists. About 26% were referred for inotropic dependence, which was a lot more than the non-heart failure cardiologists. Non-heart failure cardiologists were actually more likely to refer for cardiogenic shock and hospitalization as well. And we saw more referrals from heart failure cardiologists for pulmonary hypertension. And so, interesting things, I think, part of it is probably, related to, and we'll talk about this in the end here, sort of what, where's the location of practice and so forth, and what kind of patients you come in through. So then we wanted to see, was there any difference in outcome in patients who were referred by a particular specialty? And so when we compared heart failure cardiologists versus non-heart failure cardiologists, we found that actually heart failure cardiologists, when they referred patients, were more likely to be offered therapy. So they were more likely to be offered at least one type of advanced heart failure therapy, 66%, and statistically significantly more likely to be offered a heart transplant as well. So again, a difference in outcome there. And What we also found was interesting was that when patients were declined, if they were referred by a heart failure cardiologist, they were more likely to be declined for psychosocial reasons from a transplant and right ventricular failure from an LVAD. So just some basic conclusions and just a little bit of discussion, and then we'll open up to talk about sort of what what questions you guys have and sort of how this might relate to your own practice and ours too. But I think importantly, most of the patients in this cohort were men and they were white. And so I think that raises the question of sort of what potential disparities exist, based on sex, race, and ethnicity in our populations. And that we'll talk about here in a second. But also, very importantly, we all talk about this. We know that patients are referred very late, but this, confirms that, right? That, what we've been talking about all along is don't send patients, until when it's too late. Try and get them into your programs earlier so that we can help them, right? And so we had 63% of patients were MX 2 or 3. Those patients were very sick. More than half had an EF less than 20%. Almost 60% of the patients were either evaluated in an urgent or emergent type situation, right? So again, very sick and later than we'd want to get to them to maximize their options. And heart failure cardiologists referred the most patients, right? So why is that? We don't, it's hard to know why that's the case when we don't necessarily represent sort of the largest population of cardiologists that are out there, right? So why did we, was there a high rate of inpatient referrals? Was it because of, the heart failure cardiologist was sort of consulted on an inpatient patient, more often than not? Are we better at recognizing advanced heart failure or when's the appropriate timing, right? Which we would hope that we are, but again, is that part of the issue? And then I think that, electrophysiologists referring, such a low number, is sort of an interesting thing, because I think that EP docs are, they're in a very unique position to kind of identify factors that may be related to advanced heart failure or indicate, worsening heart failure specifically because of some of the things that they do, right? Are patients having, more ventricular arrhythmias? Are they, getting shocked by their ICD? Are they not responding to CRT after it was put in? And I think all those things are important, and what the EP docs are looking at on a regular basis. And so, thinking about sort of how do we partner again with different specialists to help maximize patients' opportunities. So again, patients were most frequently not offered advanced heart failure therapies because they were too sick, right? So anywhere between 38 and 45%, depending on whether it was VAD or transplant. Again, focusing on an earlier referral pattern, right? To try and get patients out of that category, right? Make sure that they're not too sick and they can benefit from it. And then I think psychosocial contraindications, right? Again, and up to a third almost of patients were declined for that reason. And so, I think there's a couple of things to think about with this, right? So again, pointing to earlier referral, one is, can we establish compliance, right? Can we develop a support system that may not be needed right away, but if we have patients that need help with that, if we see them for a longer period of time, we might be able to help them prepare for the need for advanced therapies, right? And I think there's a lot of mystique around the psychosocial evaluation, right? And I think that's one area to continue exploring here going forward. And I think, again, importantly, few patients were deemed too well to benefit. So again, we're not getting that many patients on the too early side, right? It's really that they're too late, more a lot. And then again, very few patients were referred to hospice or alternative treatment pathways, right? And so I think even if we can't offer VADs and transplant, we really do have to, think about sort of all these other alternatives that patients have and helping them, optimize their quality of life when they're at a end stage level of disease. And I did find it interesting based on, how much home inotropic therapy was in use, and just in comparison to our own program, we used very little of that. But I know there's some interesting research that's come out here looking at sort of geographic pattern differences in use of home inotropes and so forth. And so that kind of is interesting, I think, as well. So importantly, there are, a number of limitations to this study. I feel like this study generates more questions probably than it answers. But I think it's important for us to talk about these things, right? To kind of really, examine our own practices and understand sort of what's going on so that we can, take that information, turn that into future research and figure out how do we, maximize access for patients, right? How do we help them, get these life-saving therapies that are out there before it's too late? Again, it's a retrospective study, right? So there's, there's some limitations to that, obviously, in terms of, the access to certain data that we had, because we could only use non-PHI type information. And again, some granularity related to certain reasons why patients didn't get advanced heart failure therapies, what was the specific reason why they were thought to be too sick or too well, or what was the granular details of the psychosocial evaluation? Was it predominantly because of social support? Was it because of drug use or something like that? We unfortunately, hindsight's 2020 when you do any kind of thing in terms of research, and so you look back on it, you're like, man, we should have included these things, right? But we have what we have, and the pattern is there. And so I think it's important for us to both think about psychosocial evaluations in terms of, one, what's the contribution to outcome, right? And then is there, do programs have the same or different requirements for VADs or transplants, right? Again, speaking from our own sense, we have we have different, sort of levels of support and so forth that are required for each individual therapy. And then understanding the mechanism in which patients actually got to the heart failure cardiologist is kind of unknown, right? Are there programmatic differences in each individual place? Do heart failure patients automatically get seen by a heart failure cardiologist, or do they come from a non-cardiologist, et cetera? Things like that. Sort of, why were most patients getting touched by the heart failure cardiologist first? I think is interesting. And then again, unfortunately, the non-heart failure cardiologist specialist groups were so small that we really couldn't kind of compare each individual specialty against each other to sort of look at things on a statistical basis, but had to kind of loop them together. So in terms of future directions from this, I think there's a lot, like I said, a lot of thought generation from this particular analysis, and I think the first thing is sort of, again, because there's such a male predominated population, and are there disparities in sex, race, and ethnicity in this cohort? And we actually have a follow-up manuscript that'll be submitted any day here looking at that, and also just recently had a letter to the editor response get accepted, looking specifically at sex, so that should be coming out soon, and JCF as well, and I think really this kind of highlights the need for us to kind of, work together as a heart failure community to really sort of build larger registries, right? To be able to tease out some of these, issues on a more granular basis and sort of really look at things like geographic variation, or, get down to some of the nitty gritty things that we can do on a larger, with larger population of patients, right? And then even, prospectively follow patients in terms of their referrals and sort of like when they enter the program, how long they were in the program, stuff like that. I think there's a lot of stuff that can be done, and the larger the population you have, the more concrete you can be about your conclusions, obviously, right? And then again, investigating characteristics of psychosocial evaluations, I think, is important, because that is something that seems to be shown to be a limiting factor in a lot of different ways. And then again, working together as a community to target earlier referrals, to try and increase early referral rates, right? Whether it's education or protocolized referrals, it's things like that, that we can do together to try and help maximize access for these things to our patients, right? We all want them to do well, and we all want them to have as much opportunity to take benefit from these treatments as they might have. And so I just want to thank you guys again for the opportunity to chat today and talk to you about this research that we did here recently. I want to thank my collaborators throughout the country that were involved in this. And I hope that this was interesting to you all and educational. And I think it's, like I said, a lot of very thought generating, I think, from the outcomes of this. And I know in our own program and in the programs that we've been involved with this project have all really started to think about their practices and so forth. And so with that, I'll open up to discussion and any questions you guys might have. So
thanks so much, Jared. That was really nice. And, there's a lot of similar themes and the work that you're presenting and the things that we see on a day-to-day basis, I think. And hopefully this will generate some discussions. But to yield to the rest of the group, does anybody have any questions starting off, or any comments they would like to say regarding what Dr. Herr just presented?
I have a question. In one of the early slides, you showed 30% of patients referring for heart failure were Black. And you said, why is there a predominance of white referrals? Now, the US population is less than 15% Black, and that you have 30% referred for heart failure. So how do you explain that?
I think that's a good question, and I think we had a much higher rate of Black patients in this population. And I think I don't know if part of that might be regional variation. We had some programs that have a higher rate of Black populations in their patient cohort, but I don't have a complete explanation for that. We also had a relatively higher Asian population too, I think probably, but again, I don't. It's probably related to geographic variation based on what we have. Which again, looking at we need a bigger population. So,
do you think there'd be any role of like social determinants of health? And I would assume that probably as this field of research is growing as well, that we see the incidence of chronic diseases, that all would lead to heart failure being more common in those subpopulations of people. And I mean, I think we see the same thing. I think the patients that we take care of, there's a disproportionate number of African Americans in that group. And, my assumption is that it's because of those types of issues.
And I think it definitely is, that's definitely related. And unfortunately, we don't have all the data on what were the rate of specific comorbidities between patients and things like that to look at some of those things. But and without sort of getting too far with this other paper that we're about to submit, there are differences between, groups of patients based on ethnicity and race in our population. So I think I'll be interested to see the feedback of that and so forth when we do submit that. But I agree. I think social determinant of health and higher rates of comorbidities and rates of heart failure in different ethnic groups is certainly contributing to this as well.
Any other questions from the group?
I just have one, Mike. Hi, Jared. My name is Sharon Medor. I'm one of the LVAD coordinators here.
Nice to meet you.
Thank you. It's very interesting. I've always wondered why the rate of LVADs patients is so much less in women than men. Our program has about 2/3 male and 1/3 female. And we have found that our female patients are really the most independent. Most of them don't rely on a caregiver. They may be married, but they do their own dressings, they manage their own medications, and most of them are very successful. So I'm just wondering is it because it's not offered to them as often, or, has there been any research into, why that would be?
Yeah, I think that's a consistent theme, right? When you look at sort of advanced heart failure therapies and difference between men and women, right? I mean, I think, despite being a fairly large group of patients who are responsible for, deaths from heart failure in the US, right? Women are consistently underrepresented in both clinical trials and in you look at overall, you look at Intermax database or you look at ISHLT database, right? It's about 1/3 or less, right? Are women both getting VADs or getting transplanted. And so I think the answer to why that is, I think is a question, right? But what we can see from here, right, is and again, we have this letter to the editor, which looks at this, that's going to be published here anytime in JCF, that I suppose I can share this with you all, but that, again, we do have, less than 25, 26% of the patients in this study were women as well. But what we saw was that they were offered an advanced heart failure therapy at the same rate as men were, but they were just less referred, right? So I think the question comes down to sort of why are women not getting referred potentially at the same rate that men are, right? Is there something about sort of understanding their, clinical triggers in a different way or so forth? And again, our data is retrospective and so forth, but, again, at least they were offered at the same rate, but why that is, I think, is still a question. So, but clearly we have to target that population, right? Because there's got to be more potentially that are out there that could benefit from these things, right? So I think we have to think about, again, looking at bigger populations, looking at bigger studies in order to help us really tease some of these things out.
Chris has his hand up.
Hey, great talk. It's great to see like objective data backing up everything that you feel as a advanced heart failure cardiologist.
Right.
And so given that what you've presented, where do you think like would be good in catchment areas? What you highlighted with the electrophysiologist was interesting, mainly because if I try to recruit a EP patient, for instance, for a trial, their biggest concern is that the second that I start messing with the medications, they're worried about the referral base.
Right.
They're just like, oh, I don't want to offend the general cardiologist by sending it to the advanced heart failure doc who thinks he knows better. So where do you think the possible encatchment areas would be to kind of increase our yield of catching these people earlier?
Right. That's a really good question. I think obviously you probably guys, talk about it all the time like we do, in terms of how do you walk that balance between getting patients into your program because you know that they're going to benefit from it, but also sort of not stepping on people's toes or, impact other people's referral bases. I think, there's probably, with EP specifically, I think it might differ based on where you're at, right? I mean, in some places, EP is just there to manage a device or an ablation or whatever, and they don't really follow patients for a long time, right? So that may be some of it is sort of like same thing like interventional cardiology, you send them for a valve or a stent or something, and then they come right back to you, and maybe they don't follow them long enough. But I think it really comes down to sort of, empowering cardiologists to do what they think is the right thing, right, to help their patient regardless. But I think EP is an area to consider working with. Again, I think thinking about heart failure as sort of not interdisciplinary, but like intradisciplinary, right? We're all within cardiology. How do we work together to help manage a more complicated patient? You think of things like valve teams and stuff like that. I mean, there's no, people do that in multiple different areas, right? But I think that, looking at EP, I think also, looking at, and I don't know what it's like where you guys are necessarily, but, here, I mean, perhaps we have so many different hospitals. We have 24 hospitals in our network, just to, to kind of put it in context, right? It's pretty big. And there aren't, not everybody with heart failure who's hospitalized, right, is managed by a cardiologist. So like, how do we even just get them seen by a cardiologist to then get them referred potentially to a heart failure cardiologist? We developed pathways and so forth to try and help, funnel patients in the right direction, guidelines, all that kind of stuff, right? But it still takes the person who's on the other end of it to pull the trigger, right? We can't force people necessarily to refer to us, but it's tough. I don't think there's a good answer to that, right? I mean, I don't know, a sort of creative way of not answering your question, I guess.
No, I mean that's I think that makes sense. It's just it's an interesting question to ask of who the right person to prod is.
Right. Right.
Like if you have a general cardiologist that sends their patient to an electrophysiologist, then also auto-reflexively then prompt that person to see a heart failure person, depending on what the indication for the referral was. I don't know.
Right.
In a perfect world, I guess, as you said, it'd be an interdisciplinary approach.
I guess one thing because as you alluded to, Jared, is the difference between EP and interventional cardiology is that being heavy proceduralists. And I wonder sometimes if, the general cardiologist feels like it's something, because it's mostly medication management, right? Prior to, I guess, getting to the point where you want to evaluate somebody for advanced therapies. And I wonder if there's, this is just my personal opinion, I guess, is that maybe there's some hesitancy from general cardiologists who refer to advanced heart failure just for medication management, because heart failure is the bread and butter of cardiology. Everybody should be able to do this. But it's but then also providing the education where you're able to get them to understand what are those red flags that they need to still then look for to say, well, and that's the thing, I think, when you're looking at some of that data, it's like, it's not that the patients are any different, but you're seeing the advanced heart failure cardiologists referring more outpatients because they're recognizing those red flags, where the other groups are sending them after they're crashing and burning in the hospital for the most part. So.
And I think that's true. I think we are basically like a private practice type setting, right? And I think, everyone is always afraid to, lose their patient, right? They want to kind of hang on to things, and they, again, for a lot of people, especially those who've been in practice for a long time, right? Heart failure is mostly what you're doing, right? And, I think that sort of understanding and accepting the kind of a new specialty, right? That's not quite so cut and dry, versus EP or interventional might be, where you say, oh, okay, I'm going to send that guy because I can't do this particular thing, right? And then he's going to come back to me, and it's still my patient, right? But if I can manage medicines, then and so forth. But we all know that, right? A lot of patients are just not getting appropriate medication titration, stuff like that. All these things that, short of advanced therapies, right, that hopefully will prevent them from ever needing to get there, right? I think that's really what we want, is people to stay out of the hospital and be on meds, right? And so, I think it's tough. And, there's got to be some way to sort of like incentivize doing the right thing, right, to some degree. But, obviously there's a lot of, can of worms when it comes to that sort of thing. But yeah, and I think, and also, getting patients to advocate for themselves, right? I think that's also something to think about, right? So how do you, how do you get patients to understand and know the benefit of a heart failure specialist who may not be seeing one already, so they can talk to their cardiologist about it, right? And maybe also help with the referral. I think that's another avenue to think about.
Yeah. I think I had a question I was going to ask.
Yeah, sure.
Getting towards the top of the hour, and
Sure.
touched on some of the other things I was hoping to talk about, but I think the psychosocial evaluation issue is a huge thing, and that's something that was part of our group's discussion earlier today about some of our own candidates that we've evaluated in the past. And I think sometimes the reason we're getting into some of these difficult situations with psychosocial evaluations is maybe we're because we're seeing people late, we're not getting the chance to necessarily get to know them, and then therefore we're not making informed decisions. Or potentially the other side, because we don't get to see them early enough, we don't have the time to work with them on kind of getting those things, the modifiable risks, psychosocial risks, optimized prior to going through treatments. I don't know, what do you think about those types of ideas?
Yeah, no, I think that, again, that's, the psychosocial thing, I think is both not consistent across programs, right? And sort of like what is a psychosocial requirement, like when I was at Cedars, right, they had very different requirements than we have. I didn't say very different, but the different requirements than what we have, in terms of like at least back then, the transplant and VAD was basically the same, right? But, we recognize that there's really different needs for both of these things. And so we don't have the same kind of, maybe we're willing to stretch on VAD more than transplant, right? I think it's something you take off the shelf, right? But, being able to, look at what are the aspects of the psychosocial evaluation that were the reason why they got turned down, and then figure out sort of targeted interventions to try and help that, right? And I think a lot of the times, at least in our program, it's, maybe they don't have someone to help them, it's really, sort of caregiver support, right? And then you have to wonder sort of how important is that if someone's, you have these sort of like loner patients, right, who have lived for however long on their own, if they just get someone to help them get to and from their appointments until they can, drive themselves basically, do they really need 24/7 care? I don't know, that sort of thing. So
It's a good point. It's a point that's been raised by our coordinators previously as well for our LVAD team that, some of our patients that don't necessarily have social support do just fine. So,
yeah, and we have lots of patients like that, so.
Yeah. Well, any other questions out there from the group before we wrap up? Yep, Dr. Kopf.
I just want to clarify what you mean by heart failure cardiologist. So there are heart failure cardiologists in the centers, and there are heart failure cardiologists outside the centers. Now, is there an issue with heart failure cardiologists within the institutions that some are more likely to refer for transplantation or mechanical device? I didn't quite understand what you were comparing.
Yeah, so we didn't differentiate between sort of the heart failure cardiologist within the institution or outside the institution. We basically defined the referring physician as the first cardiologist that saw the patient and then referred them for advanced therapy. So like it may have been a heart failure cardiologist who's in the community, right, who then sent to your program, and so really you end up getting seen two heart failure cardiologists, but the first cardiologist that saw the patient was a heart failure specialist, whether it was affiliated with a transplant program or VAD program or not.
I see. Okay, well, it might be interesting to compare the two different
absolutely.
types of quote heart failure specialists.
Of course.
There's quite a difference. Yeah.
I bet.
Okay, thanks.
Thank you.
All right, everybody. Well, we're just about to 4 o'clock, so we'll go ahead and, well, it's almost, I guess, 1 o'clock out on the West Coast in sunny California. But thanks so much for taking the time to join us today. And wish you all the best, and hopefully we get to meet sometime at a conference or something and keep talking about these types of things.
Yeah, I would love to. Well, again, thank you guys again for the opportunity. Really had a pleasure doing this. And if you ever have any questions or anything, feel free to reach out. I think Michael has all my information. So happy to chat for more and be on the lookout for some more data that's coming out from this trial. So
all right. Thanks so much.
All right. Take care.
Bye, everybody.
Bye, everybody.